Well, hello, doctors. Those of you who've logged on, I wanted to welcome you to our webinar. I'm Dr. Ataii. I'll be talking about micro-osteoperforation, talking a little bit about clear aligner cases that I've done, including how do we make these cases that we see every day with whether we're doing Invisalign or any kind of clear aligner treatment. And some of you doctors who do wire and brackets, frankly, talking about the orthodontics in tracking, accelerating, and some of the waves that we see in orthodontics that are changing the way we're moving teeth. So again, my name is Dr. Ataii. I've been an Invisalign provider for the past now officially 10 years, I can tell you that. And in the past decade, I've learned a lot about plastics, clear aligners, how do we move teeth from a general dental perspective, and how do we actually engage with our patients so that time that we spend with them is spent wisely, effectively, and making sure that our teeth track to where we're planning on moving these teeth to. Because a lot of us understanding that the problem sometimes we have with clear aligners or wire and brackets is time becomes an issue, tracking becomes an issue. And those doctors who are listening, I see 101 signups in attendees. That's great. We're going to have a Q&A section. We're going to talk about how I was able to do some of these treatments from 6 millimeters of crowding, 4 millimeters of crowding, some of the advanced movements in less than a year time period, and some of which less than even 6 months period. So we're going to go over case after case after case and really understand the parameters of what is Propel, integrating this product into our practice for orthodontics, and understanding that some of the advanced cases that we see in our general dental practice, and we're going to go through talking about how I've been able to combine including the fixed restorative into my treatment planning, because now I get predictable movements. I know where I'm going to be in less than a year's time. So let's get started. I hope that those of you who are finally all logged on, I've got you taking a look at my case that some of you might have seen just recently published. This patient actually came in not because she had a diastema, and those of you who heard me on the lecture circuit, it wasn't because she was worried about cosmetics. If you look at the x-ray below your screen, it was because she had an extraction done by another dental office nearby. I'm in Laguna Hills in South Orange County, California, and she wanted to get a cheaper pricing on implants. Her main objective and main goal was whether or not she can have a product that can be less than what the other doctor is quoting her, which is an implant. And I kind of posed a question to her. Well, I understand that you're trying to get a better pricing, but let's take a look at your bite. Let's take a look at what we see on tooth number 14. And some of you see the extrusion of number 14. And looking at that space, it looks like a recent extraction of number 19. Putting that aside, she has a spacing on the anterior 8 and 9. No problem. I'm not worried about cosmetics, but I have no canine guidance. If you look at tooth number 11, there's a space between 11 and 22, the opposing tooth. There is no cuspid rise. So what's going to happen, no matter what pricing I give her, as soon as I place an implant, as soon as I do the restorative and the abutment, I have to either shave tooth number 14 down because I don't have enough room due to that super eruption, or I'm going to have to give her a short abutment or a short clinical crown, and her bite is going to be an issue. She's going to potentially have that implant get loose, and here I am discussing these cases with her. Money is no longer the problem. And I always say the byproduct of a good bite is having a nice smile. We're going to talk about these kinds of cases of how I've integrated orthodontics, restorative, and incorporating what I like to use as the Propel product in accelerating and expediting my treatment, staying on track. You look at this case, she's got a flared overjet, she's got a spacing. I would have to lingualize these upper anterior arch. By the time I lingualize, I could potentially create more of a problem by posterior open bite. So I'm going to have to now move the lower arch. I'm going to now have to intrude tooth number 14. If you look at the bone, she's got dense bone. So bone density becomes a problem when we're doing orthodontics, especially with clear aligners. So let's talk about her case, and I'm going to give you the photos that we started. back in 2013, you can see the red marks on the left of your screen on the upper arch, the slight rotation on the lateral, diastema on the upper. Again, my big problem of not having a posterior proper occlusal contact, super eruption of 14. And we're going to discuss her case. But before we do, I need to talk to you about how and what it is that I incorporate. And looking at the density of bone, orthodontics with clear liners, with a piece of plastic, moving teeth, how do we do that? Well, let's have that discussion. Let's talk about how we got her to this point. Let's talk about how we were able to finalize her treatment when her chief concern was money. How do I spend less money with you, Dr. Tai, than the office next door? And guess what? She didn't spend less money. We ended up doing the orthodontics. We did the Invisalign. We corrected the occlusion that needed to be intruded, give her a better bite, placed the implant. This is over a $10,000 treatment plan, which now she's excited. She has a better smile line. Her whole family's coming over to me. And that's what I like to discuss on the dentistry today, talking about current controversies in dentistry. Accelerate tooth movements, is that working or not? So let's have that discussion. What are the common denominator in every one of your cases? What is a common denominator in every one of your cases that you see from an overjet, from an open space to a crowding? Again, I had to explain myself 10 years ago, and here I am talking to you doctors about something that's revolutionary of how in the world are you able to move these teeth without root resorption with plastic only? How are you able to do these? And every one of these cases we're going to discuss were done in less than a year time, some of which are 6 months. The case below that I will show you, that was done in less than 4 months. How are you able to do that? Well, first, case identification becomes important. Posterior teeth versus anterior teeth. From a GP perspective, looking at every one of these cases, the common denominator is bone. When you want to move teeth, you're moving teeth in bone, not jello. And looking at the overjet of tooth number 11 on the bottom of your screen, and it being lingualized, creating space, creating the proper movements, interproximating, all of these are part of your calculation of tooth movements. And again, bone is a common denominator. So let's talk about patient motivation. When you start to talk about these cases and say, hey, patient, this case is going to take me 2 years or 2.5 years. 54 patients were interviewed as to what was the reason that you didn't quite start the treatment that the doctor advised. And most of the patients, out of 54 of them, when you look at it, it wasn't because of money. It wasn't because that they had, bad aesthetics. They understood they had bad aesthetics. They understand that they had missing teeth that needed it. But their biggest problem was duration of time. 31% of patients said, look, it's going to take too long. It's a commitment for me. I don't want to do it. And that's sometimes we have to take that into our treatment planning because we don't want to have it where our aligner stops tracking. Once the aligner stops tracking, now we're going to have an issue, doctors. Patients are not happy. The aligner's popping off. And those of you who are doing clear aligner treatments, you know that every one of these cases, from posterior teeth where teeth may not track, maybe we didn't do enough interproximation, maybe the patient wasn't compliant, maybe the seating wasn't well, or the teeth didn't rotate. The teeth has to rotate in bone, in that dense bone. Maybe the intrusion, or sometimes you see those laterals that don't track well. Some of you doctors are seeing posterior open bites. Every one of these cases, and if you're not doing enough IPR, some of you doctors might be afraid of doing the IPR. And the reality is, each one of these factors are contingent of time, space, and pressure. And I've always said, you want to move teeth, you need to put pressure on the tooth, you need to create the space, and you need to give us some time for the bone to catch up. That is the most important portion of orthodontic movements when you're getting to these minor tooth movements. Again, I don't practice orthodontics on a day-to-day basis. I'm a general dentist. My main agenda is looking at the 6 anteriors, posterior, how they bite, how they land. And I give my patients the full orthodontic wire and bracket option. They go to the orthodontist that I refer. Then they come back to my lab and say, well, can you just fix these 4 or fix these 6? And the reality is that becomes a problem. I'm kind of trying to give them sort of a pseudo treatment plan rather than a full treatment plan. Because that lateral didn't track, I'm going to now bond the lateral. So what I'd like to talk is I had to learn how to minimize my refinements, eliminate some of those, prior to, some of you guys may do some Invisalign treatments and mid-course treatments or other clear aligner treatments. It does take time. Turnaround time of 3 to 4 weeks sometimes. Patients are staying on that same aligner. The bone is becoming dense again. That time, space, pressure. Now you remove the formula of pressure. You've removed the formula of time. And now you're stuck with just waiting for the next set of aligners to come. All of these tend to create a problem. So I'd like to discuss what is micro-osseous perforation. How is it that it's enabling us to, as clinicians, to kind of remodel the bone? Is it safe? What is it? I mean, how do I do it? How do my patients benefit from it? So whether you're doing clear aligner treatments, as I mentioned before, conventional orthodontics, understanding that by creating a small micro-osseous perforation, what does that mean? We are taking a small bee sting looking to the gum line. If you take a look at your screen, this is what it looks like. It's not an injection. We're not putting in something in the patient's body. We're not lifting the gums and doing a surgical procedure. We're simply creating where we're just like we're giving our injections. Sometimes you guys do the infiltrations or the block. And if you look in this particular case on your upper screen, I had actually created a small little infiltration that's at the mucogingival area, with the vestibular area, vestibulo-mucogingival area is. And then in the attached portion, I kind of went in and created a small little perforations in the gum, just tapping the bone. That's it. We are using the Propel technique and the Propel device in small little areas of creating that depth of quite small fractures in the bone. What does that mean? When I say that, I don't mean you take a high-speed drill and drill into the gum. There are multiple devices that Propel is coming in with drivers, power drivers, and we're using the science. And I say we because I feel part of the company now. I feel that in my 54 cases, they have helped me succeed in tracking, in being able to create these aligner treatments that I wasn't able to get in the past 9 years. So harnessing the patient's own body in accelerating that biological density of bone. What does that mean? Well, first, there's multiple drivers. One are ones that are basically disposable tips or single-use drivers. These are inexpensive drivers that I always like to disclose to doctors is less than a few $100, and that gives you only need to do once. One of these tips or maximum 2 throughout the entire ortho procedure of the patient is all you need. You don't need to go back and create those perforations again and again and again. And I'll show you some of my cases. On average, most of my patients that I'm treating with these mild to moderate crowding or spacing cases, they're only getting one treatment of Propel. That's it. And it helps create the patient's biology, which I'll explain to you in just a few minutes. Understanding, doctors, that again, that's what it looks like. I always want to be clear with clinicians who are not used to this and looking at it, and they say, oh my God, what are you doing? Well, we give infiltrations all day long. This is not as bad. And by the way, these are my earlier cases. I'll even show you the perforations now that you can barely see and what they look like. You become proficient in everything you do as you get better and better. So New York Clinical Studies, New York University had started these studies, and it's showing the effects of osteoperforation on the rate of tooth movement. And obviously using the Propel device to create these micro-perforations. And it demonstrates that these cases you're able to increase the velocity. What does that mean? You can change the aligners faster. You can change those NiTi wires. You can bring the patient back and have those, instead of 14-day change, you can now change them sooner. And by creating the bone, accepting the tooth movements, you've now changed, and you can change the aligners sooner. There's some doctors that change the aligners every 3 days. Some doctors do every 7 days. I'll also give you my formula, what I do in my practice. But now you're able to move the tooth bodily rather than just tipping it. And there's been no root resorption, as you can see with clear aligner treatments, specifically with Invisalign. And now you have a bone adaptation that you're able to move teeth. So in orthodontics, understanding how this works is important because the rate of bone remodeling, as well as the pressure you're putting on the tooth, it determines that patient's treatment time. Why do we say that the teeth aligners need to be changed every 14 days? Why is it that every 2 weeks the patient's changing? Whereas I've been practicing changing them every week. Well, by creating the micro-osteoperforation, I'm now reducing the amount of what we call the density of bone locally and creating more of a stimulation. And you create that osteoblastic, osteoclastic activity. So let's get into some biological mechanical terms, and some terms you need to know because your patients are going to always ask, well, what's going on? And I'll discuss how I talk to my patients because it's very simple terms. The first time I'll see you, patient, I'm going to put on jackets on your teeth. Those are the attachments. The next time I see you, patient, I'm going to, do some interproximation, put your teeth on a diet. And then I'm going to wake up your bone. Or we're going to do all of that on that first visit. It really depends on your clinical savviness of how you want. Me, particularly, I like to start my entire treatment all at once. I like to get the perforations out of the way. I like to put on the attachments, do the IPR. That's all done. Now the patient changes the aligners, every week rather than every 2 weeks. So the biology is important, understanding how this works. Just going back to your dental school days, doctors, you have to understand that you're looking at where the bone, right now, without any gum tissue or any attachments or any free gingiva. So you've got about 1 millimeter to 2 millimeters of bone that's covering the tuberculae of bone. And in the tuberculae of bone is where your roots are positioned. Well, okay, we understand that. There's another millimeter or 2 millimeters of gum tissue over the bone. So at maximum, you have anywhere between 3 to maximum 4 millimeters, unless if you have osteotosis of some sort, of tissue and bone. Well, that's why when we are going in, and if you start to create some sort of stimulation, heaven forbid, but if those of you who have broken bones, the doctor says, oh, by the way, when this bone fuses together, you're going to have a stronger area on that bone. Why is that? That area got stimulated, new osteocytes, new osteoblast and osteoclastic activity, osteocytes proliferate faster, and you end up getting a much better, stronger bone on that fracture area. That's a fact. Now the question becomes, how can we use that in using that cellular activity to our benefit? And how do we create what's called a cytokine activity? And cytokine activity basically is what? Is the stimulation as you create that traumatic area, the area where as soon as you tap the bone, if you will, as soon as you hit that periosteum area, as soon as you kind of perforate the outer portion of the bone. I don't mean going all the way to the tuberculae. I don't mean going into the root of the tooth. I mean just simply like you're drilling a drywall into the wood. As soon as you hit that wood, just like you'll feel it tactile, you then create that small little stimulation of osteocytes. And osteocytes start to proliferate. You end up getting inflammatory responses, which cytokine activity at that point increases. So orthodontic forces do the same thing. When you're trying to move teeth by putting on some sort of a force, you create inflammation. Inflammation starts the cytokine activity. The body says, oh my gosh, we've got to go heal this area. And what happens? Automatically your body inflammatory response is high, is trying to heal the area, and you get the higher cytokine, bone starts to remodel faster, hence you get tooth movement to whatever direction the force is. Now, if we can create that small microperforation, directly go to the inflammatory process, increasing the inflammatory process, increase the cytokine activity, all the immunoglobulins of your body says, hello, there's a problem, let's go fix it, that cellular activity, bone starts to remodel. Now, what I tell my patients, instead of having dense, strong bone, I'm creating that local area of jello. So no matter what size attachment, what size force you put on, you're creating an area where the bone gets stimulated and that proliferation of the cytokine and the bone remodeling starts to happen. So now I can put the force, I can move the tooth, and I can change the aligners or wire and brackets that some of you doctors are doing faster. I don't have to wait till the bone to catch up. Remember, doctors, Those of you who are used to giving patients a lot of Motrin or a lot of Advil, during orthodontic movement, you want inflammatory process. So don't tell the patient, hey, you're feeling a little pain with your ortho, take Advil. No, because what is that doing? It's telling the body, I'm here to help you. We're going to reduce the inflammation. We're going to help you, and that's not what we really want. You can give them Tylenol. We want the inflammatory process to be strong. If you're doing a root canal, give them Advil. If you're doing a crown prep or some sort of filling patient has pain with, give them some sort of anti-inflammatory. During orthodontic movements, you want the inflammatory phase to be high. Those of you who haven't heard this before know that releasing those challenge movements, releasing those fibers, the radicular fibers, the Sharpie's fibers, all of those are contingent on the tooth going into a new position and new fibers start to form. So we're going to have to use force. We're going to have to use some sort of a pressure to move the tooth into that space. Now, does that mean that every patient's a candidate? No. In my office, I don't treat patients with orthodontics using the Propel technology or the Propel device with patients who are on steroid treatment, patients who are taking anti-inflammatories. And there are some patients who are on chronic steroid treatments. I don't use it for them. I don't use it on patients who's taken what I call the Sally Fields drug, the bisphosphates, the Fosamax or any of those, Boniva. I just don't feel comfortable doing ortho on them, and I don't know. I know some research says it's up to 7 years. After 7 years, it's already dissolved in the patient's body. I don't treat those patients who've had history of the bone building pill, as well as any patient who is compromised, obviously, and pregnant patients can be thrown in there too. So those type of patients I don't treat with any type of accelerated type perforations or movements. Now there are multiple devices, multiple ways, multiple processes in you creating these acceleration or cytokine activity. Some of you doctors may have heard of some of them, but let me just give you a quick review of what I used to do, and I always show this to doctors. I never knew what the word Wilcodontics meant. All I knew is that there's a severe crowding or a severe orthodontic movement that I need to have done. I'm going to send it to my orthodontist, and my orthodontist does a great job in those cases. My patient's already accepted. And then I send it to my oral surgeon, and I just cross off the word Wilcodontics. And after 6 or 8 months, the patient comes in, and magically his teeth are straightened. I never knew how they're doing it till I saw what Wilcodontics is. And if you look at the processes on the top of your slide, that's Wilcodontics. It's doing a full flap, taking the drill, and literally creating those small little micro lesions on the bone. You're not going through and through, just small little corticotomies into the bone, and with the wire and brackets or clear liners. And in this particular case, the patient had a tooth that was projecting anteriorly forward on 20, I think it's a lower incisor. And they extracted, and the patient was trying to get married and wanted the teeth closed up faster. And so in less than 6 months, the patient got nice and straight, as you can see on the bottom of your screen on the right side. That is one option. Not an option that I like to propose to my patients, but until about 3 years ago, I was sending my patients to my oral surgeon and my orthodontist. They would talk, and patient would come back, nice straight teeth, under a year. Another option is the soft tissue method. You can actually take the scalpel and create the collars of the gum and kind of tap on the bone. That's another option. And those of you who've seen this, it's creating that cytokine activity, inflammatory process. So now you can move and get those movements faster. The vibration method, given that the amount of vibration put on the tooth, and some of you know some of those products, and I know that there's been a lot of talk about how does it work, does it not, and the frequencies, and all of this is another technique instead of using your high speed. I know some of you doctors say, you know what, why do I need to spend $150 or $160 on this type of a product? Well, I'll tell you why. Because if you start to use a high speed, even with the smallest 2-round burr, or some of you might think of some orthodontists, I know there's a few of you on listening, you end up having some of you could use TADs. the TADs and all those processes to put in anywhere between 20 to 40 microperforations that looks very small is very difficult of it not breaking. Remember, the Propel device is a end-cutting stainless steel surgical device used for spine surgery. You can take a hammer to it, and I'm going to tell you, doctors, very difficult to break that tip. And that's the only device that has some sort of an insurance, which I think it's up to 3 million or 5 million, not quite sure how much, that the doctors get. Not a single fracture has happened with a TAD, using a high-speed drill. What are you going to get? Well, let's discuss that. Using a high-speed drill, you're going to carve out the bone. You're going to actually have that smooth area. You're actually augmenting the bone. That is not going to fill in. What we're talking about is small perforation where the bone fills in after you stabilize and move the teeth. Microperforations of 0.3 in diameter maximum is not the same with the 2-round burr, okay? Because you're scooping out and removing bone. So these micro-osseous perforations and the procedures for them is important. Those doctors that understand, I always like to kind of, either you can use a topical. There is a profound topical. Those of you who can get, it's, and some of I can email you back that profound topical. Most of the compound pharmacies do them with the perlicaine and tetracaine, or you can just do a small infiltration. I have the patients rinse with some chlorhexidine for about 60 seconds, and I set the tip, and you'll see what I'm talking about, at the 3 millimeter or 5 millimeter. The tip actually has a setting that I can go and tap the bone at 3 millimeters, or if it's exostosis of bone or very thick, dense bone, at 5 or 7 millimeters. And I place the device in between the roots. So there's a consent form, there is a rinse. All of these are done with my patients. I've put the consent form on my site, Ataii.com. Those of you who want the processes, consent forms, and this webinar, I'll also post, you also have it in the Propel site. It's just telling the patients that, we're going to go ahead and do a perforation, and it's a technique for orthodontic treatment. And we kind of explain to the patient that there is, an alveoplasty or some movement of bone that we're going to be doing. And, we're remodeling, and, we kind of make sure the patient has that kind of a consent. That's online you can get. I evaluate the X-ray, obviously, or have them rinse, and you're going in between the roots anywhere I like the attached gingiva of 2 to 3 perforations. Now, what that means is that I'm not going to go on the root surface, on the prominence of the roots. Now, remember, you're only doing 3 millimeters at maximum, or wherever you feel the bone. Some patients have very thin gingiva, and they have very thin bone, so you're only going in about 2 millimeters. You'll feel it tactile, but you can hit 2 or 3 perforations. I like the attached gingiva. I like it where there's very minimal bleeding. I don't go on the free gingiva. I don't put it in the vestibular area. As you can see on my photos, it's exactly where the attached gingiva is. In some areas, I do 1 perforation. In other areas, 2. So on the slide that you see on the top, I did 2 perforations on the upper arch from molar to central incisor because I was distalizing. I was moving this entire arch back. I need that bone to cooperate. And I only did 1 perforation on the lower arch because the attached gingiva was very minimal. I didn't have a long, wide attached gingiva as I did on the top. And that's enough to create the cytokine activity and the inflammatory process for me. The lower is a crowding, the upper is a spacing with an overjet. Again, we'll review some of these cases. Those of you who have the ClinCheck software and do Invisalign, you can kind of see I've marked it in blue where I'm going to put it. And some of the roots are angled, as you can see on the canine tooth number 11. The root kind of looks angled, so my perforations are going to follow the parallel of the root. I'm not going to go and nick the root. And by the way, I have a video. I've actually gone in where patients have been quite a little bit infiltrated. As you start to go in on the prominence of the root, I did it on my wife, so we'll just keep that off record. And patients start to feel a little bit of heat and kind of like an electric shock because you're not really going through the cementum. What you're doing is you're pushing the tooth first. As soon as they feel that, and if you continue to twist and continue to twist, you're going in 7 or 8 millimeters now, then the patient starts to feel pain. So when you're starting with these perforations, there's really no pain. It's just pressure. So A lot of doctors worry about nicking the root. Well, it's just like doing your first crown prep. Until you do it, I will tell you, you're not going to become proficient at it, but don't put the device or the tip right on the root, in between the roots. Done. Here's a video I can show you in much better terms. So we're back, Dr. Ataii. As I mentioned earlier, we have a case. We're going to show you how to do the Propel. Patient in for Invisalign treatment of 24 aligners from an anterior view. As you can see, there's intrusions going on, some resolving of the lower crowding. I'll show you a mandibular view of what's happening. The mandibular view, from the beginning to end, we're rotating on the teeth axis. And what happens in order to do that, we need to have a bone that's going to cooperate with us. I like to propose Propel. My patient's already accepted. I always like to show the patient that we are taking a sterile bag. The device is a device which is simply, as you can well see, that's the numbers on it. We're going to go ahead and set it at 3 millimeter. And I always like to use the Vaseline and kind of just put it so on the lips of the patient and along the device itself. So let's go ahead and see how the device will work. We're actually going to start with the number 27 area. Small little pressure. Simply, as you can see, we're in. That's typically 3 twists and back. That's as simple as the device. How did we do?
Excellent.
Excellent, the patient says. So this is actually my assistant. So she, as we said, as you heard earlier, I had to do some rotations on the tooth. It's on the tooth. I couldn't procline forward. She had a deep bite, and you'll see her case in a minute. And I wanted to kind of rotate on their access, and basically going into proximally at 3 millimeters and in between teeth at the gingival at the attached area. And this is what she looked like immediately that day when we did the Propel with the micro-osteoperforation. That device you saw was an earlier ones that are the entire device is a throwaway. Now a disposable. Now I use the tips. It's cheaper for me because I have the disposable tips with the handle. And Propel just came out, which I just purchased, a power-driven one, and I love that one. The power-driven device is awesome, but that's what it looks like first week, right? So a little bit of rinse. That's right after I was done with the Propel. Not much bleeding, very minimal areas. Couple of bee stings that I like to mention on the upper arch, and areas that you can see on the lower left arch on between tooth number 26 and 27. I put 2 perforations, some areas with 1 perforations, on the upper with 2 perforations, and then you can see on 22 and 23 with 2 perforations. A week later, I took the picture, healing area. You can see she has some bone, dense bone on the molar area. Those areas I had gone in 5 millimeters, but on the anterior I only went 3. And here's what she looks like in the 3-week timeline. Pretty much all healed, just like any other bone that you did a gingivectomy on, or any other process or procedure. So her case was a lower crowding with an upper deep bite, some spacing. I had to bring the uppers back. I didn't want to procline the lowers forward because I was afraid she's going to get posterior open bite. I added some IPR, distal of the canines, and that's it. We wanted the teeth to rotate on their axis. So using the Propel, she was 26 aligners, 52 weeks, 13 months is what we were supposed to do. Here she is in the 6-month time period, kind of finishing up, nice bite, nice smile, and this is just a year follow-up to show the stabilization. I always like to keep this patient in the stabilization form. So my office instructions to her and to all my patients is change the aligners every 7 days. I get the patient in. The very first visit, I put on the attachments, I do the IPR, I have them rinse. Whether you decide you're going to infiltrate, in her case, we just did the topical to see whether or not she has pain or not. We did some profound topical for her, and we started the delivery of the Propel on the gum tissue, and I instructed her to change the aligners every 7 days. Increases predictability, and the patient then got done with the heavy movements the first 6 months. And the rest, I didn't have to do another Propel. So the follow-up was just stabilizing, make sure the bite settles, getting her in retention. Some of you who already are in Invisalign or clear aligner treatments, you want to start it reactively, you can start it at whatever stage. And you can take new impressions if you like, or just start the Propel and have them change the aligner every week. I know a few orthodontists, and a handful of them are changing every 3 days using Propel. That's completely up to you. I'm at this point at a 7-day interval. Makes sense for me. I see the patients every 6 weeks. Again, some of the patients I don't treat, as I mentioned earlier, are the steroid pregnant and the ASA3 patients. I have built in a cost for my patients for Propel. I don't include Propel as part of my treatment on some of the cases. But understand, I have a level 1 and level 2 pricing. What does that mean? I have where there's simple cases and I have difficult cases. So those of you who understand what a simple case is, is it a simple or difficult case? Well, looking at her to give her a pricing of what it is, some of you offices have only one stand pricing. This is greater than 6 millimeters of crowding in my world. The lower arch is going to take a minimum of at least a year treatment. And those of you who are looking at her case, she's got lower crowding, upper overlap, a little bit of overjet. She's got a deep bite, or at least a deep smile line. And we've got to upright the posterior molars and premolars. We're going to spend a good significant time in getting those premolars back on the bone. Again, this case is not considered a simple 10-aligner case. So for my pricing, this will be considered an advanced case in my office, not a simple case. And for her, I'm going to discuss doing the clear aligner or the wire and brackets. She did not want to do the wire and bracket treatment. She has very long roots on those canines. The overlapping you can see on the incisors. Again, very long roots, very dense bone. So I'm going to have a difficult time and making sure that she actually stays compliant. We're talking, and those doctors, you guys might be able to educate me more, there's no way I can finish this in 6 months or less than a year. Well, using the Propel, you can see what she started in November of 2013, and we had started some of the Propel treatments for her, and as you can see, I started her reactively putting the perforations, and as you can actually hear her testimonial within 3 months, her conversation was, look, I don't see teeth moving. So I tell patients, here's what's going to happen. The first week, you're going to hate me because we're going to wake up your bone. We're going to put a little perforation on the bone. We're going to put on attachments, and you're going to have to change the aligner every 2 weeks. Every week, I apologize, every week. And in about 3 months, you're then going to thank me, and that's when I need a new referral from you. Because after 3 months, you're going to see significantly, compared to your other friends who are doing Invisalign or clear aligner treatments, you're going to be much more advanced. And here she is giving us a quick little testimonial.
Hi, it's me, Lorena, here at Dr. Atai's office, and I wanted to share a little bit of my experience with you guys. I've had Invisalign for 3 months and did the Propel, and I'm seeing a little bit of movement. I can feel the movement. My bite's better, and I'm looking forward to all the change. Propel has allowed me to change my trays every week instead of every 2 weeks, which is great because they don't smell as bad.
So they're very excited that they don't smell as bad, and here we are following up her treatment from where she started with the overlapping from an overjet view and looking at her 6 months down the line and the follow-up of the year. The tissue looks better. This is not Photoshop. This is actually her gums, just like how periodontists flap and kind of clean the teeth and you get that stimulation, new growth. The gums look better, the teeth look better, and we're able to now combine our restorative into these treatments. Again, looking at these patients from where they were before to in the timeline, it's important. So we started in our conversation with the space, the diastema. We started our conversation about that extruded 14. Let's talk about her case. Her case started with a conversation of, yes, I like to do some Invisalign treatment. I like to intrude, but you have a little bit of exostosis on some of these bones. You can see tooth number 3 and 14 and 13. I need to intrude those. I did create a virtual tooth for her implant, and we started with the Propel treatment. And at 3 millimeters, I started to anywhere between 1 to 2 perforations I could put in. But on the posterior teeth, I went in 5. So tooth number 14, tooth number 13, I went in at 5. And the reason for that was because I need that intrusion of the molar. Remember, it's got 3 roots up there, so it's going to be hard for me to intrude greater than 1 millimeter with clear aligners with plastic only. Even extruding teeth is difficult. And even with the CT, I was able to, that same day that we perfed for research purposes, I actually took a gutta percha and put it right in the area of the perforation that you can see that on the top of your screen. That's an actual gutta percha where I tracked my perforation to show that I did go in between. And I wanted to see what happens 5, 6 months, a year down the line. Is that area going to heal? What's going to happen with that area? So this is at the initial site. As we went and we started to get the intrusion on the teeth, the lining better, I'm now able to place the implant. Remember, I'm not propelling beyond tooth number 20 because I don't want the bone to get stimulated in the areas that were not moving teeth. So I stopped my propel. If you recall in that photo, or earlier photo, I stopped my propel right before tooth number 19. So just at distal, because you get about 6 millimeters of that little I like to call it that little area of movement. So in that 6 millimeter diameter is where we're trying to see how much is the effective movements of these teeth. And again, I can now place my implant on 19 safely while I'm moving teeth at the same time, while I'm intruding. So the implant was placed, getting a better occlusion. You can see the diastema on 8 and 9 starting to close. And a year follow-up, post-implant, post-ortho, you can see the bone actually became more dense. I was able to get better tissue, stronger bone, post-ortho, post-propel treatment. Now remember, I only propelled her once through the entire treatment. That was just one propel treatment and device. And as you saw earlier, this is a year later, completely completed with the ortho, with the implant, and the follow-up. And look at how much nicer her tissue is. And to me, these are the kind of treatments that I like to render in combining my orthodontics and restorative, or ortho only as a general practitioner. This is why I fell in love again with clear aligners, and I've accelerated my practice to us just kind of marketing and advertising. And here I am, a disruptor in the community of talking about, hey, we can now do these cases. We can take these cases that are severe overjets. We can take these nightmare cases, and we have a treatment now that can be effective, whether you use wire and brackets, in tracking, having dense bone. We can now take these 12 millimeter overjets, which are severe cases, lingualizing them, propelling them, and the entire time having the patient change that aligner every week, being able to follow up with the patients and having the proper treatment guidelines that the ClinCheck software tells us with Invisalign. So in this particular case, you can see my problem with the overjet. In the ClinCheck said, sure, you can actually distalize and get that done. Well, that wasn't the case because I have a 12 millimeter overjet. I'm going to need the bone to cooperate. So in getting her to this point, I was able to, as you saw earlier, propel, have the patient change every week. I created some spacing in between the premolar and canine, but I got a little bit of posterior lift on the molar. Why? Because I didn't follow my own instructions of interproximating. I was worried about IPRing too much. Well, as the tray's lingualizing and bringing back, it lifted number 3 up. So now I would need a second propel in this particular case. I treated her twice with the perforations, and being able to land that tooth, cutting the trays, and having the posteriors drop in, and finishing her, where everyone told her there's no way that clear aligners would work. She was getting married. She didn't want to do wire and brackets. And as you can see, within a year time, we were able to take this severe nightmare to somewhere where it actually changed her entire bite, entire movements, and she was much happier. So again, tracking and incorporating propel or micro-perforations, any technique you bring is going to have some cost associated with it. In my world, it is $100 to $150 additional cost for my practice, but I've been able to, as I discussed with patients, if you're greater than 6 millimeters of crowding or in an advanced level in my office, this is an option we have now. And pretty much all my cases now, I'm propelling. and pretty much all my cases, I believe, whether they're simple or hard, I'm using it. And I give my patients, look, you can actually have where we're including the Propel into your treatment. There's my fee, and again, I've loaded all of these for you doctors. You can actually go on my site, and you can go ahead and download. It's editable. You can put your own fees. But if you see on your screen, I simply talk about advanced case, what your pricing is, and in California, Southern California, about $5,500. Or you can pay a la carte for it, patient. It's about $500 for the Propel treatment. Typically, it depends on your patients and how you render the services. Understand, you can actually bill for these for the medical or for the dental insurance. It is considered alveoplasty without extracting of teeth. So, you know, some of you may want to use the billing codes. If patients have some sort of insurance, you can do that as well. But, you know, my fee is typically about $500 a quadrant, depending on if you're going to charge a patient extra $2,000 for Propel, or you're just going to include it in the treatment, or you're going to give them at a $500 fee. That depends on you. In my practice, I'm charging per quadrant, and you know, we don't, because I'm their GP, because I'm their doctor, you know, I try to not to give them a hard time to have extra added costs. So the $500 covers me, and that gives me enough time to have the patient finish, have the patient have proper treatment, and now the cost is something that we can either pass on to the patient or incur on our own, depending on your practices. So I've left a few minutes for us to have some Q&A. I know some of you doctors are already online, so I'm going to pull the questions out. Why do you need multiple perforations in the same area? Doesn't one perforation have a 5 millimeter radius or effect? Yes, it does. So the question is, why are you putting in multiple perforations? And the answer here is, if you can look at my screen, is, look, I can put one, but depending on the density of bone and depending on where the attachment is, and extent of the roots, some roots are short, some roots are long. So I'm going to go ahead and at least put in the 2 perforations on the attached gingiva. The more inflammatory process, the better. Now, have I run science or research that 1 perforation is just as effective as 2? I have not. And the reason is I'm trying to create as much as I can in creating that perforation. It is a 5 to 6 millimeter radius, depending on the density of bone. So that's something that I'm doing. But there's, you know, the question of, is there a need for 2 or 3? The answer I have for you is that's what I'm doing currently, and as long as there's attached gingiva, I'm going to continue doing wherever I have that room. 1, 2, or 3. If I have room, I'm going to go ahead and create that perforation. And whatever teeth you're moving, by the way. Some of you may not be moving any molars or premolars. Some of you may only be moving the canine or the rotation that you have hard on the canine. Then go ahead and do that. But remember, if you're telling the patient to change their aligner every week, you have to make sure that the entire tray and the entire teeth are tracking. So that's another question of, do we perforate all the teeth or just the ones you're moving? And the answer is, whatever teeth you're moving, you're going to probably want to consider the perforation that you're going to have to change the trays every week. I hope that answered your question. The next question I have here. So there is absolutely no, hold on a second. So there's absolutely no risk of separation of instruments. So the answer is, not a single one has been reported as a separation of instruments. And doctors, let me tell you this. I took a hammer in front of my rep. My rep is a Propel rep. Her name is Kelly. I took that hammer, hammered it because she told me it doesn't break. And no, it didn't even bend. Now, if you keep hammering the thing, it will bend and break, right? But no, there is absolutely no risk, and they have an insurance for us for that. That not in my malpractice. Propel itself has a separate insurance that will cover us through them if such a thing happens. And it hasn't happened up to 600 perforations. So my answer to you is no, absolutely there is no risk that I see in separating the instrument. Now, with other instruments, there's possibilities. I haven't tried other instruments, but I've heard of multiple problems of breaking of some of the doctors are trying to use the TADs because you're taking in The TAT instruments you're taking in and putting in multiple times. So the question is, I'm confused by how many times Propel is indicated per treatment. How does one decide how often to Propel treatment? I've heard every 12 weeks, every 6 months, and now once in a treatment. Okay, let's go ahead and clear that up for you. A typical Invisalign case does mild to moderate cases. Those Invisalign cases are typically anywhere between 24 to 26 aligners, okay? In looking at these cases, you're going to have to now evaluate, okay, how many aligners am I getting? Well, in Invisalign, I can tell you the first 10 trays have most of the movement built in. So in my world, I start the Propel right away, and I have the patient change every week, and I evaluate because the cytokine activity in your body, think of you doing implants. Doctors, when you extract a tooth, after how long does the bone start to heal itself and you're ready for an implant to be placed? Typically 3 to 4 months. So the cytokine activity when you make these perforations last anywhere between 3 to 4 months. Now, if your heavy movement's done by the first 10 aligners, that means that the first 3 months or 4 months of the treatment, you've actually moved all the heavy movements. So do you need another perforation? In my case that I just showed you, in this case, I didn't need it. But in the class 2 case I did, I had to do another perforation. So in her case, after the evaluation of the 3 months, I brought her back and we redid the Propel. Okay? So the answer to your question is typically you need it one time because most of your heavy movements are done in that 3 to 4 months. Now you're just fine-tuning. And do you need to do additional Propel? That's a decision you make. On mild to moderate cases of 6 millimeters or less, I'm going to tell you you're probably going to need only one Propel treatment, and that's it. Okay? Next question. Is the super erupted case where you wanted to intrude the upper first molar, would you ever consider perforation on the palatal? Great question. There are some orthodontists that are doing the palatal perforations. And the answer to that is, I'm afraid. I'm afraid of where the nerve is. I know some doctors that are doing the perforations right in the lingual of the lower arches. I know some orthodontists that are doing on the palatal for the canines that are buried in, and you're trying to, they're using YM brackets, and they're trying to bring those canines into place. So the answer to your question is, I'm afraid of palatal. I haven't done it. Have I considered it? I know that a lot of doctors have done it, but the buccal to me seems enough. I went in 5 millimeters there, which I showed you on the CT. The patient post-op looked great. If anything, I got more dense bone. And hope that answers that question. Doctor, how many patients are you treated with Propel? Is there any long-term study? Is there any post-treatment gingival recession? Great question. I've treated now to date, I'm just hitting under 64 patients. At the time when we did the last year webinar, we had done about just 38 or so, hitting in the 40s. So every one of my cases now, in the past 30 of them, I've been taking CTs. I have a cone beam that I purchased 1.5 years ago, and I'm CTing and seeing the long-term on my end. Gingival recession, your next question, is there any recession? The answer is, if you are proclining teeth forward and leaving them there with traumatic occlusion, you're going to get gingival recession. But if I'm putting teeth in the proper 1 millimeter overjet overbite, no, I have not gotten recession because of Propel. I may have patients who I didn't quite finish in my earlier cases properly, and they have an edge-to-edge bite or some canines that are fully rotated. Yes, potentially those get some receded, but not the Propel cases, not when I'm finishing an ideal finish in the past 3 years. So I can tell you, in my world, I haven't had issues or have seen it. Now, I've been doing Propel the past 3 years now. It's officially about 3 years now that I've been taking these perforations and been doing the micro-perforations. Okay, Dr. Peak, can you autoclave the tips to reuse in the same patient? The answer is no. These are one-time use only because these tips, they get blood over them. They get bone, sometimes fragments in them. And for you to clean them and try to throw them away with these tips, unfortunately, they don't, they melt. So maybe that's why I like these disposable tips that you see. I'm a much more fan of the handle, the driver. And just recently, I purchased the power driver, which I will hopefully on the next webinar, I'll show you how I'm using the power driver. And it's basically an electric button I press and it goes into the bone 3 meters and comes right out. No more twisting on my end. But again, those are disposable tips. I cannot autoclave or reuse them because of the bone and blood that sometimes gets in there. Now, when I say bone, remember, when you're twisting in, you're then twisting out. You're not pulling the teeth out. You're not pulling the tip out. So again, some doctors want to try to do that autoclave thing. It's not made, and the FDA doesn't approve of that either. Okay. If the roots are long, would you go more to the level of root apex per patient? Yes, absolutely. So the question is, if you have long roots, and let's talk about our case here with where I have very long roots, would you be able to go in? You can. Remember, the more apical you make your perforation, the better. The more closer to the root you are and stimulate that area, much better. I just don't personally like it because of the bleeding, because the mucogingival, where's the root? You're at that mucogingival area where potentially you could get some bleeding. That's the reason why I don't go down to the mid-root level. If you look at my perforations, I can go as far as right to the apex, but then there's some bleeding there, and the patients sometimes freak out. That's a decision I've made, so I only put it on detachment. Remember, most of these research that is done at New York University and some of the other research that are done, they do from apical all the way up to the free gingiva, anywhere to create that 5 to 6 millimeter diameter of stimulation, if you will. Okay, so it's just a personal choice that I've made because I don't like patients seeing blood. Okay, so all right, Dr. Peak, one more time. Do you have experience and success with fixing a posterior crossbite with Invisalign and Propel? Does this take longer? Okay, so let's talk about posterior crossbites. Okay, posterior crossbites tend to have a little bit of an issue. Plastic alone can give the force of maybe 1 millimeter to 2 millimeters of posterior crossbites. So these posterior crossbites can be fixed given you are within the parameter of the 1 to 2 millimeter of uprighting, or a line calls it expansion. So if you have a posterior crossbite of at least 2 millimeters or less, then yes, it should work. Outside of that, I don't think it's going to work. And, you know, no matter how much you propel, you can't tell the plastic, hey, I want you to put more force and expand yourself. Now, having said that, I know Dr. Shipley, I know a few doctor orthodontists have expanded up to 4 or some of them close to 5 millimeters of expansion, meaning uprighting the molars in correcting these crossbites that are greater than 4 millimeters. In my world, 2 millimeters is my cutoff, and that's about the amount of expansion I do. And yes, I do propel them, including distalizing up to 1 millimeter like you saw in my class 2 case. Okay? And one final question, we're at the top of the hour, Dr. Mike Rebel, when the insurance company asks for narrative for the treatment, how do you respond? So yeah, in my narrative, I tell them alveoplasty with non-extraction of tooth using Propel. So I simply tell them what I'm using, per quad. And in my narrative, I do say, because I'm typically billing my patients on the quadrant, I'm billing the insurance. I don't bill all 4 quads. Sometimes, I just give it to the patient. It depends on, I don't want to create an insurance problem for myself either. So simply on the treated areas, I'm telling them I'm doing it on the quad, and that's about $500 on my quadrant fee. But I do say alveoplasty non-extraction of teeth using Propel device. And that's pretty much, just like Arrestin. If you recall, when Arrestin came out, it was called antimicrobial below gum line or something like that was the narrative. Now you just put in, Arrestin, and everybody knows what that is. So, there is no Propel code for it. There's just like how, we have to kind of put the verbiage, but I do put that narrative with my before and after photos if they ask for it. Okay? I hope that gives all you doctors at the top of the hour some extra tips and tools.